Renal denervation was a promising approach to resistant hypertension until the SYMPLICITY trial came along. We are still learning from this trial, including a review topic of the week, and it is in the November 1st, 2016 issue of JACC. And the paper is Regression to the Mean in the SYMPLICITY HTN-3 trial, Implications for Trial Design and Reporting. To talk about this, I'm with Dr. Stuart J. Pocock, who is a PhD, a professor of medical statistics at the London School of Hygiene and Tropical Medicine in the United Kingdom, correct?
That's correct.
And we are talking about the SYMPLICITY HTN-3 trial. I suppose the nice place to start would be remind us about that trial.
Well, that trial and also the history before it, because there was tremendous optimism for renal denervation. SYMPLICITY 1 was an uncontrolled trial and they saw fantastic reductions in blood pressure. Then SYMPLICITY 2, a smaller, poorly controlled trial, seemed to be equally optimistic. And so they went into saying, now we've got to do the proper trial to convince the FDA this works. So the proper trial, SYMPLICITY HTN-3, had a sham control. So a control group thought they were getting renal denervation and they weren't. And that was an important way of removing any bias in the comparison of the two groups. And they were dismayed to see that the sham was very good. And you could reduce blood pressure, mean blood pressure across quite a large number of patients without any active intervention. And then the active procedure did just fractionally better, but not significantly better.
So why did you do this review paper?
Because we thought we need to understand better what actually happens to blood pressure over time in patients who are being entered into trials. There was talk of inadequate procedure being done, and there was talk of placebo effects, and there was talk of regression to the mean. And we wanted to tease out what was the contribution of regression to the mean in seeing these rather substantial falls in blood pressure. So that's why we started.
Now, my older son graduated from Duke with a degree in statistics, so statisticians are near and dear to my heart, let me put it that way. In this case, we have regression to the mean. Now, that goes back 130 years, so remind us, what is regression to the mean?
Well, you and I are getting on a bit. We don't go that far. So just to say what it is now, rather than the history. It is stick to blood pressure. When a patient comes in with a high blood pressure, meriting considering renal denervation, you consider, well, it's plausible that they're on a random high compared with their true everyday blood pressure. And therefore, they're there because they've got high blood pressure and you want to do something about it. But any patient tends to enter a trial or a new treatment when they're on this random high. They're above what you'd normally expect. And therefore, as a patient gets followed, you expect their blood pressure to regress to their underlying mean that they would have typically over time. And therefore, we knew this in drug trials that a long way back, 25 years ago, that if you put patients on placebo, it's not just the placebo effect, but they regress back to their true mean, and you see quite substantial falls in blood pressure.
And so that's why SYMPLICITY HTN-3 is a perfect study for what you're talking about here.
That's right, but it's not just patients regress to their mean. The higher the baseline blood pressure, take a patient with 200, you can anticipate in advance. They are more likely to have a more substantial fall than a patient who comes in with a baseline blood pressure of 160. So you see that more substantial falls will happen the higher the initial blood pressure. And when you analyze any of these studies, you need to take that relationship between change and baseline into account. The typical analyses in HTN-3, as published, were just looking at change, ignoring baseline. So what our paper contributes is, do you gain more insight by studying the relationship between the change and the baseline? And so we've done that in a statistical technique called analysis of covariance, which doesn't go back 130 years, but it goes back many decades. So we're not doing anything startlingly new. We're just trying to re-educate the medical community, cardiology, renal denervation communities, think smarter about blood pressure and what actually goes on. I think the other thing we illustrated is blood pressure is incredibly variable. they still, the treating physicians will still think, I expect the patient blood pressure to fall by a certain amount. But it's not like that on an individual basis at all. There's tremendous variation.
Well, even over a very short period of time, you're supposed to take a blood pressure several minutes apart, because you will see in your office, you will see a range of blood pressures.
That's right. In fact, for entry into the trial, we said you need also to get smarter by having a well-measured baseline. I measure it more than once before you start treatment.
Right.
And we saw even between baseline measures, only a month apart, untreated, or maybe it was 2 weeks apart, you saw a dramatic reduction, a change from one baseline to another, even before they entered into the trial. And that's why quite a lot of patients who are being screened to enter HTN-3 never made it.
Right.
Because good for them, they got better while just being observed.
So what are the implications for trial design and reporting, which is part of your title?
I think we need to recognize when you have any quantitative outcome, could be blood pressure, could be LDL cholesterol, could be HbA1c in diabetics. You need to get smarter in recognizing this regression to the mean phenomenon. You need to recognize that the falls you're going to see may have nothing to do with the actual treatment that you'd like to see being ineffective. So you need to see treatment effects studied after you've accounted for regression to the mean and see what the treatment adds on. So in the new trials of rethought out renal denervation with new methods of delivering it, they are feeling their way with somewhat smaller trials to see if, when you analyze it properly, there's enough of a signal coming through to then launch into the major phase 3 trial. So if you like, the renal denervation community are licking their wounds, getting smarter statistically, we're trying to help that along, and seeing if there's real signals that could come through still with better device, but better analysis and better planning of the design.
Precisely. And so this paper that we've been talking about with Dr. Pocock is in the November 1st, 2016 issue of JACC. Please see that. For CardioSource World News, I'm Executive Editor Rick McGuire.